would also like to thank Bart for inviting me to speak on this topic of lab TAPP repair tips and tricks. It's an honor to present this talk in front of a very august audience, which includes my own mentor Prakash sir and the doyen of laparoscopic surgery in Kerala. So when we talk about tips and tricks in any surgery, it does not mean that we are talking about the routine steps which you read in the textbook or obviously on YouTube. Tips and tricks mainly means with the topic what I mean to say in the next 10 minutes is that what a modification surgeon has done over his experience to make the surgery more easier, comfortable, and produce better outcome for the patient. I have only one disclosure that I mainly do only TAPP repairs, and this presentation is in no way a recommendation that TAPP is better over any other form of repair. Any form of repair is good, but I am comfortable doing TAPPs, and in future maybe I'll try different types of hernia repairs. So just quickly into the principle of TAPP repairs. It's a transabdominal preperitoneal technique where you enter the peritoneal cavity, incise the peritoneum, enter the preperitoneal space, reduce the hernia, place mesh over the hernia site, and close the peritoneum and come out. So I'll go through the steps step by step, the approach step by step, and what all tips and tricks I have to share with you over my 2 years experience in Apollo. I'll be sharing with you. And I'm pretty sure that after this talk, my mentor will have more points, much more points to add than what I present in this talk. So I'll go step by step. First is patient positioning and pre-op preparation. We always catheterize the patient, however it's not mandatory. If you are expecting the surgery to be difficult, it's a large hernia, it's always good to catheterize the patient. We do it routinely in a unit. You restrict the per and post-op fluids to prevent post-op retention. Obviously, for all our cases, we always go for ultrasound abdomen, no matter the patient is young or old. You have to evaluate for prostate and other intra-abdominal masses. And more often than not, you'll find a contralateral hernia as well, especially in case of an elderly patient. In such patients, we take a consent for a bilateral hernia repair. And many times you find that when you go inside, you have a bilateral hernia repair. Position is supine, monitor is at the foot of the patient. Surgeon stands opposite to the side of hernia, that is, if you're doing the right hernia, so on the left side, shoulder end. And my camera person stands at the head end. And obviously, you need to have adequate support because the patient will be going for Trendelenburg. And on the clinical side of the surgeon is standing. That means you're doing the right repair, the patient will be having a slight right up. So into the peritoneal cavity, establish new peritoneum. I prefer doing the open technique. That's what we practice in the unit. You can use the varus needle as well. 10 mm supraumbilic port around 2 to 3 cm above the umbilicus. 2 5 mm ports at the level of umbilicus and midclavicle line. You inspect the peritoneal cavity, reduce the hernia. Note the hernia on the contralateral side. Notice any of the hernias like a suprapubic hernia or a femoral hernias. We use the EHS classification and we classify the hernias accordingly and note it down. And obviously, you have to get a pretty optimal operating position and instruments so that you don't get tired when you're doing this hernia repair. Sometimes it will be tiring when you're switching the peritoneum at the end of the procedure. So this is a slight modification that we do when we do the bilateral TAPP repair. We use the supraumbilical port and 2 ports at the level of the umbilicus. However, when we are doing the right TAPP repair, you can see the left hand working port slightly lower and slightly more through the medial side. This helps in reaching the side of the hernia, and this port goes up slightly bit more up. I have noticed that I have slight difficulty in reaching that side, and we have to push the port bit more inside. And slightly making this slight modification helps us reaching the access in the side better. So after into the peritoneal cavity, you have to reduce the hernia. This is an important step. If you have a large hernia with a lot of bubble inside, usually once the mucoperitoneum is created, the bubble usually comes out. But in such kind of large hernia, sometimes it's difficult. Be very careful. Hold the bubble gently. Don't hold the mesentery. Just hold the bubble, and whichever part of the bubble is coming out easily, just keep pulling it. And you can just push it from outside, and the bubble will generally reduce by itself. Sometimes this step is tedious, but usually just come out. Going to the preperitoneal dissection part. So the entire idea for this part is to create an adequate preperitoneal pocket after reducing the hernia, so that you can place a large mesh. So for going to this step, you need to know all the anatomical landmarks. I want to go into the detail of the anatomical landmarks. You need to know where your median, medial, and lateral ligament is. You need to know the inferior gastric vessels. You need to know where the pubic is, the inferior bladder, and the Cooper's ligament, the iliac vessels, corona mortis. You have to identify the sac, relate the cord structures, and the vast difference. And you have to create the upper flap of placement of mesh. So we usually start 3 cm above the AS ideas. We palpate the AS from outside, mark it with a hook or a cautery or scissors, and then we extend this incision, peritoneal incision, and about 4 to 7 cm above the defect. I usually use the monopolar hook. We tattoo the incision. You use the pneumoperitoneum CO2 for dissection. The flap has to be thin. The fat belongs to the abdominal wall. This is very important because most of the time when we start our career, we tend to be very careful not to create buttonholes in the peritoneum. So we take the fat with the peritoneum, and it leads to bearing of the muscle, which is not allowed. At the middle end of the incision, there can be a slight extension vertically, which will help you in the medial dissection. I'll show a small video of it. And when you are doing the lateral part of the incision, you can just bend it downwards like an inverted U, which will help you close the peritoneum at the end of the procedure. And I usually do a lateral to medial dissection. So here I am marking the incision from outside. Here the AS is here, mark the incision, and we tattoo the incision going up to the medial umbilical ligament. So this is important. You can't go to the medial umbilical ligament, you will injure the bladder. You go up to the medial umbilical ligament, you make a slight vertical extension in this area so that the dissection is easy when the flap is raised. And then after the incision is marked, no matter it's the first case or the 100th case, we always do this. This is a standard procedure which we follow. We don't change the steps no matter how much experience we have. And then after that, we just hold the peritoneum, make a slight incision, let the CO2 do its job. There will be a slight new peritoneum. And then once you start dissecting, this is what I was mentioning, this is the fat part which has to go up. And ideally the peritoneal flap has to be very, very thin. And then you create the flap, and then you keep on dissecting, and you reach the medial umbilical ligament. Then you need to identify anatomical landmarks. TAPP repair is a beautiful surgery. If you go in the planes and you identify all the anatomical landmarks, it is very easy and it is very satisfying surgery where you feel very happy after the surgery. So you immediately dissect and develop the radius space. You see the lighthouse one, you see the pubic bone, the white pubic bone. That means you have reached you are in the right place. You follow the pubis and reach the sac from the medial end. And obviously you have to identify the two dangerous triangles, the triangle of doom and pain, which we have been reading since MBBS days. It was a entrance question as well, the boundaries of doom and pain. And you have to identify the other potential hernias. So this is the triangle of doom, and which contains the great vessels, the iliac vessels, and this is a triangle of pain. And for obvious reason, you are supposed to be very careful in this region. If you happen to fix the mesh in these two regions, you'll have to fix a lot of things later in the surgery. This is the inferior gastric vessel, medial to the direct hernias, lateral to the indirect hernias. Small video of the medial dissection. So after creating the peritoneal flap, you can just use a hook forceps. Hook instrument, and it's a very very comfortable instrument to use. You can just open the fibroidal planes, and in the right plane there will be no bleeding. And then you can use a combination of blunt and sharp dissection. You can this is the bladder which has been pushed down by a blunt dissection. Here you see the white sign of a lighthouse sign coming up. This is the bone. Once the bone is visible, that means you're the right plane. You can just keep developing that plane of that bone and reach the pubic bone. And you can see here the medial side, the lateral side, the medial end of the hernia is visible here. So we're just developing the bone, the medial dissection here, trying to delineate the anatomical landmarks. You have to reach the midline and slightly lateral to the midline to the contralateral side so that the mesh can be placed nicely. This is the midline and this is the slightly lateral side. This is the bladder which has been pushed down. And this is the hernia. So after the medial section, this is for the picture. You will see this is the left side hernia. You can see the midline, slight lateral contralateral dissection. Inferior also 2 to 3 cm you have to dissect to make sure that the landmark is clear. So after dissection, here in this case, you can see the triangle of doom very clearly, the vast difference between testicular vessels, the lower peritoneal flap, and the pubic bone, the Cooper's ligament, iliac tract. And in this case, the patient was very thin, and with this peritoneal flap, we have taken a part of this fat also, so you can see the nerves visible here, which is not supposed to be ideal. How to dissect the hernia sac? So you have to enter the type of hernia sac. When you enter the abdominal cavity, only see which kind of hernia it is and make sure that you are not dealing with any other abnormal form of hernias. You dissect the hernia sac very carefully, separate from the cord structures, try not to injure anything, especially if it's a very young patient, male patient. Identify the vas and keep it under vision all the time, otherwise you will end up injuring the vas at times. And you should be careful while dissecting lateral and inferior to Cooper's ligament, that is the area where you will find the great vessel. So this is the area which I am telling you to be careful. This is the area where the fat of fat is there. Keep dissecting in this area and hit this area, you might injure the iliac vessels. Hernia sac, dissection of the direct hernia sac is very nice to do. It's a very gratifying step because it comes out very nicely no matter how big the hernia is. You just do a traction, contraction, you see a white pseudo sac and you just push it and pull it and it will be reduced. And after reduction, you feel very happy. So, it's a good step to do in surgery. So you dissect the sac anteriorly and keeping an eye on the vas. And what we do is usually to reduce the incidence of seroma formation post-operatively, which is pretty common after a large direct hernia dissection. We hold the pseudosac with the left hand and just anchor it to the Cooper's ligament with a tactor. So you can see the white direct sac here. It's being pushed by the right hand and the left hand is keeping a constant counter traction on it. Here a large sac is being fixed to the Cooper's ligament using a tactor. So small video of a direct sac dissection. You can see the direct sac here. The white direct sac is being just pushed away, and the lower flap is being, the flap is being lifted and seen from the below how much direct hernia is there. And with ease of dissection, you can simply just reduce this kind of hernias. Most of the time, it comes very nicely, and after the dissection is complete, you can see now the entire pubic bone is very clear and the hernia has been reduced. So later in this hernia, you can just invert it and fix it to the corpus ligament for preventing of any seroma formation. Indirect sacs are really a pain. No matter how many hernias I have done, I always have difficulties. It's a very large, long-standing indirect hernia. The anatomy is very difficult to identify sometimes, and you should be very meticulous and take your own time. You should not look at the clock when you're dissecting a long-standing indirect hernias. So I usually start laterally, I define the sac laterally, use short bursts of cautery, whatever sling fibers are there, try dividing them. Keep identifying the cord structure at all the times, separate from the sac by using a combination of blunt and sharp dissection. Invert the sac and keep from inside. You can just pull the sac from inside and invert it, and you might see the edge of the sac. Then you immediately have to identify the vas and separate from the sac. Very important, you're not supposed to injure the vas at any point. And you have to be very patient in such a long-standing indirect hernias. You have to be very patient, do meticulous dissection. It's bleeding. Just keep a gauze piece ready, keep adequate pressure, and the bleeding mostly stops. I use short burst of bipolar cautery. A complete hernia with large sac, it's very difficult to take the entire sac out. You ligate and divide it as distally as possible. Make sure that you are taking a proper hemostasis, otherwise it will lead to hematoma formation in the post-op period. Limits of dissection, medially you have to see the pubis symphysis 2 cm to the opposite side, below the pubis 2 cm, and the turning of the vas medially. Inferiorly, the flap should be big enough to place mesh without folding. The mesh has to be placed properly. Laterally, there should be clear delineation of cord structures, triangular pain, and should be large enough to place the mesh. And superiorly, you have to raise the flap by pulling it. So the small video of limits of dissection is the bilateral hernia. We have developed a space on the contralateral side. So the bilateral hernias are grown quite a lot to the left side as well, so that the left side becomes easier. However, on a unilateral hernia, you don't have to go so much lateral on the contralateral side. Since the entire pubic bone is visible, the bladder is pushed down nicely. This is the triangle of Doom. You can see the vas deferens, testicular vessels, the external artery pulsating nicely. And here's the triangle of pain lateral to it. And below you will see the peritoneal edge reflected nicely. Here is the peritoneal reflection. And here the upper flap has been raised by just pulling it enough to place the mesh. And here is the inferior epigastric vessel you can see in the roof. So after creating an adequate space, you deploy and anchor the mesh. What we usually use is a 15 to 30 centimeter standard size mesh. It's a 15 centimeter mesh. I find it is too big for any kind of hernia, so we usually trim it down to 13 centimeters. A proline mesh which is folded in a cylindrical shape, 2/3 to 1/3, and tied at center with a 2-0 proline. And I put an air knot. So after you put the air knot, you place it inside. It's very easy to cut. And you place through a 10mm camera port. The lower middle free end of the mesh, we take it to the pubis and anchor it with a tacker. So once you anchor it, the mesh is quite stable. It doesn't wobble here and there, so you can easily cut the suture and can unroll it. And then we do 2 more fixations, medially at the rectus and lateral extent of upper end of the mesh. And we should make sure that there is no crumbling or rolling of the mesh. Small video of the preparation of the mesh. We just roll it like a cigar in 2/3 to 1/3. And we take a 2-0 proline. This 2-0 proline then we later use to close the peritoneal defect as well. And we usually do a air knotting so that this knot is easy to cut when the mesh is placed inside. So after the mesh is inside, you make sure that the free edge of the mesh is at the corpus ligament. You fix the tacker. Once the mesh is anchored, then it's very easy to unroll. Due to the air knot, you can just use one hand also cut it, and you can take the stitch out. And once you then unroll the mesh, when its pocket is quite nice and large section, the nice section has been done. The large pocket is there. The mesh will tend to unroll nicely, and you can just put the lower flap of the peritoneum and place the mesh there. And once the mesh will usually sit if the dissection is adequate. If the mesh is not sitting there, it's unrolling, it's rolling again, getting crumpled, that means the dissection is not adequate. And then we do 2 more fixations. Usually 3-point fixation is enough. If it's too big a defect or something, then we usually put an extra tacker. This is the 3D mesh from Bart which we used a couple of times. I would admit that the introduction of the mesh to the 10mm camera port was a bit difficult, but after the mesh was placed, it actually started quite nicely, and it took the shape of the hernia cavity itself, and so it was quite easy once we deployed the mesh. So peritoneal closure, we use 2-0 proline usually. I usually close from the right of the patient to the left. So if I have a right hernia, I stand on the left side. start from right to left, and then for the left hernia, I again go from the medial to lateral aspect. It may vary from surgeon to surgeon. I find it more comfortable, so I choose that way. I usually use interlocking sutures while using Prolene. It helps in two ways. One, I don't have to keep pulling the suture after every bite. It usually stays. And at the end of the suturing, if the thread is quite small, I can't take a bite to. I can take a knot to tie it at the end of the pregnant closure. You can just make 2-3 interlocking sutures and it usually stays. There's no problem. And the entire flap needs to be closed without any large buttonholes. If you have a large buttonhole which you are not able to close by any method, easier method is to just take the extra sac that you get, that you can usually take bite from the peritoneum and the extra sac you have. Last case we had a very big buttonhole, so what we did was we used the tinea color of the colon, we just took an anchoring stitch and it stayed nicely. And obviously no part of the mesh should be exposed after the peritoneal closure. So after the closure it should usually look like this, watertight compartment closure. And after this, you just remove all the ports in the region. You remove the needle under region by through the 5mm port along with the port. And 10mm port I usually close with the port closure needle number 1 bicycle. Post-op, we inflate the wound with local anesthesia, remove the catheter same day evening or the next early morning. Mobilize the patient early, start on the same day, and usually I discharge the patient on the next day morning. Now, some tips for special situation. If you have a bleeding, what to do? So never get scared if it's a bleeding. Also, just keep a gauze piece handy. Give some pressure. Use short bursts of bipolar cautery, and usually the bleeding stops. Use pressure. If you have a bleeding, just use pressure. Keep it for some time. Don't get anxious. Sometimes you have to use 2 to 3 gauze pieces also if it's a very large indirect hernias, but still it ultimately stops. Large hernias, reducing them is a difficult task, especially if it's an indirect hernia. Be patient. Keep pushing from outside. Keep revising the anatomy again and again. After 5-10 minutes, again stop. See where you are, what is going wrong in the anatomy. Try to see the edge of the peritoneal edge, and then keep pulling and pushing from both the sides, and ultimately it usually comes out. Quite often we see umbilical hernia with inguinal hernias. In such cases, if it's a small umbilical hernia, I usually put the camera port through the umbilical hernia and repair it anatomically. If it's a large hernia, we give the choice to the patient: either we do an anatomical mesh repair of the hernia after the TAPP repair, or we do a pipe pump repair. Hernia in females is another interesting thing. Here you have to be careful that in females you might end up missing a femoral hernia or operator hernia. So make sure that you find out those hernias, and usually I divide the round ligament when we do hernia in females. Hernias with the TAPP you will get very often. We are operating very lot of elderly patients. These patients, in the initial part of my practice, the urologist used to do TAPP first, and they used to do the hernia. In the same sitting. But then we was finding difficult because they have to irrigate the bladder continuously. So doing the hernia surgery will become difficult. So now we have shifted to doing the hernia first, then they'll do the TAPP. Parietal hernias, you have to dissect from the opposite. I usually prefer dissecting from the right side itself because I'm a right-handed surgeon. I find right hernias to be much more easier for me technically. So I do my dissection maximum from the right side. And after both the meshes are placed, this is the right hernia and this is the left side mesh. It looks like somewhat like this from a different angle. So quite often we see on the left side the sigmoid colon. This is the sigmoid colon. It's adherent to the peritoneum here. So we have a tendency to release these adhesions. It's not required because if we try to do this, we'll end up causing more buttonholes in the peritoneum. Usually our incisions will come in this area, and no adhesions usually will be found in this area. So you can just go ahead with your peritoneal flap creation, and this once the flap comes out, this segment will not cause any harm to your surgery. Only thing is you have to be careful that when you're coming to the hook or scissors in this area, don't independently injure the sigmoid colon. But there's no point in taking those adhesions because more buttonhole deformities. You have to be aware of the other hernia. This is an interesting case which we had. Right hernia was done years back, open surgery. He came with the left hernia. Inside the found a suprapubic hernia as well. So after repairing the left hernia, we created a small flap of peritoneum in the right side, and we reduced the suprapubic hernia and placed a small piece of mesh over the suprapubic hernia as well. In our experience over the last 18 months in Apollo, we have done around 126 cases. We had around a serum of 12, and which in 3 cases which we had to aspirate the seroma. The patient ultimately settled down, and the rest of the patients, the seroma settled by itself. We had 2 conversions, pretty interesting case actually I would like to share. So first case was a recurrent inguinal hernia which was open, so we planned for lap repair. He had also a history of umbilical hernia repair, mesh repaired on outside. But when we put the first port, the open technique we used was a umbilical port. The incision of the umbilical hernia was quite down, the previous umbilical hernia. So I put quite a port for putting the camera. When I put the camera, my colleague pointed out that we are actually doing a colonoscope by using a laparoscope. We are in the colon actually. So we had to convert it, we had to repair the colon. We proceeded with the open hernia repair again. The patient post-operatively did well, but he had some wound infection, so he developed the incidental hernia there, which we had to repair after 6 months. Then the other conversion was a patient which was a very hefty patient. He came with a typical symptom that he had to push on his right inguinal region to go to the urine. So probably it was a bladder as the content. So when we went inside to the laparoscope, he was almost 95 kgs. And it was very difficult. The bladder was going inside the hernia, and I actually could not make out the pubic bone, and I could not add the landmarks. And I tried to reduce the bladder from outside, and I thought we are causing more damage we might into the bladder. So I thought it was more, intelligent to convert it rather than causing damage to the bladder and causing more issues. So we converted the case. It opened up and went pretty nicely. For the newbies in the crowd, this is what my advice is after all these experiences, that your case selection should be good. If you select a small direct hernias in a thin elderly patient, in there you will get a very good anatomy. You can see all these landmarks very clearly. You will be very happy. You get the confidence in the starting part of your career. And you should always work up the case well. Always do ultrasound. Never omit all these investigations. Look for the prostate. How large the prostate is. The patient having urinary symptoms. Look for any internal pathology other than the hernias. And take a history of previous surgeries. Don't miss this previous surgery history. Otherwise, you will end up in trouble with a lot of other issues. Always take a consent for open surgeries. Catheterize the patient. It doesn't cause any much harm to the patient. You just put a tube and take it out the next morning. Go slow. Do a very meticulous dissection. Take hemostasis. Don't miss the landmarks. Only after identifying the landmarks, you should proceed. If you are having any difficulty anywhere, just stop, take a break, put a gauze piece, and just come back after a minute, and maybe things will be much more clear. And always call for a second opinion if you are having any doubt. Even if it's a junior or some other unit surgeon, you can just call and ask for help. So that's what I believe in. If you do keep doing the same steps repeatedly, no matter if it's the first case or last case, keep doing things repeatedly. Have a protocol, have a procedure book in your OT. And don't omit any steps, you will definitely reach excellence. And thank you everyone for patiently listening. Any questions, I will be happy to answer.